I'm incredibly grateful to Aki, Camilla, Irasima, and the entire organizing committee for the opportunity of joining you today and sharing a little bit about our personal experience. I have to confess, after our town hall this morning, I am humbled, and I think you all should be up here instead of me. But I am delighted to have a chance to share a little bit about, I was going to say my journey, but really our family's journey, and hopefully share some suggestions that may prove helpful for those of you facing stomach cancer as well, or your loved ones who may be in that situation. Greg, I don't know if you can hear me, but I may ask you to help with advancing the slides whenever I say next. Thank you, Greg. Perfect. And next, thank you. And we did hear a bit about this earlier, but cancer, as we know, is a formidable disorder. Nothing that I share personally today is intended to substitute for the guidance that individuals should obtain from their own care teams, except when noted, the suggestions that we share during this talk reflect really our personal experience and are not necessarily evidence-based. I apologize that due to time constraints, some of the slides will fly by very quickly, but all of today's talks will be available on the stocan.org website after the meeting for review at a more leisurely pace. My story, next please, Greg. My story, next, thank you. Began back in prehistoric times by oncology standards in early 2007, when as an apparently healthy and active surgeon and father of young kids, I was unexpectedly diagnosed with stage 3B signet ring stomach cancer. I underwent a total gastrectomy and Roux-en-Y reconstruction. Multiple lymph nodes were positive. Next, Greg. Which was not good news, certainly in terms of my prognosis. After research and email consults with folks in the US, Europe, and Asia, I ended up with 4 months of chemo to try to eliminate residual cancer cells. At this point, it was September, 8 months after my surgery, a couple months after finishing chemo. I was really excited about getting back to work. I was still having some discomfort eating and had a CT scan to evaluate this. The scan revealed that my GI tract was actually fine. I was shocked, however, next, Greg. Thank you. To learn that the scan showed a metastasis in my liver. In the scan image on the right, we can see the liver metastasis, which typically has this punched out appearance surrounded by the red box here. This was bad news. Next, please. I now had stage 4 metastatic cancer. As we know, the anticipated course of events is progression despite additional chemo, with most patients dying within 15 months, as seen in the graph on slide right. The goal of therapy, as we've already heard this morning in our discussion for patients with metastatic cancer, has traditionally been to buy time, as cure is generally not considered possible. To try to improve on this prognosis, next please, Greg. We tried a clinical trial of what was then a relatively new treatment approach, namely targeted therapy, this directed against c-Met, a protein involved in a number of types of cancer, including stomach cancer. Things were stable in the trial for about 3 months or so, but then progressed. I failed. I came off the trial. Over the next 14 months, we tried a lot of things, including 2 more types of regular chemo, another clinical trial targeting that c-Met pathway, electrical current applied via a needle introduced through my skin into the liver to destroy the liver metastases, and even a major surgery during which part of my liver was removed. Nothing worked. I had multiple related medical issues, including a collapsed lung and a severe spine infection requiring emergency surgery and 8 weeks of home IV antibiotics. I was developing more abdominal pain, and my liver function was failing. At this point, I would likely have only one more shot at treatment. We were looking at another trial targeting that c-Met pathway, but wanted to make sure that we chose the option that was most likely to be successful. It was at this time that we came across an interesting article by a research scientist who specialized in this c-Met pathway that we had been targeting. I emailed the scientist, who very kindly agreed to study my tumor tissue in his lab. These specialized studies, known as proteomic studies, next please, Greg, basically looked at tumor protein activation, and they revealed that the c-Met protein was not, in fact, overactive. The scientists kindly looked at other proteins, though, and found that a protein known as HER2 was. At the time, it was recognized that HER2, next please, was overactive in about 20% of patients with breast cancer. This was before the TOGA study, which led to a greater appreciation of the role of HER2 in gastric cancer. Well, this information was exciting news, as there were two agents, next please, Greg, already approved by the FDA as effective against HER2-positive breast cancer. These drugs, called trastuzumab and lapatinib, act at different points along the HER2 pathway. Since trastuzumab was already approved by the FDA for breast cancer, next please, Greg, my oncologist was able to obtain approval for me to receive the drug on an individual patient basis outside of a clinical trial, what's called expanded access. This is basically actually a very humble version of what is now being done so elegantly for so many patients through the TAPR program that Dr. Mangat just shared with us. 3 days after getting my first IV infusion of trastuzumab, next please, my right arm became very swollen and painful. It turned out that I had a major blood clot involving the veins of my arm and neck. Next, please. Blood clots are actually a very common and potentially life-threatening problem associated with various types of cancers, as well as their treatments. I was put on an anticoagulant, next please, and continued to receive trastuzumab. At the 1 month point on many clinical trials, and we adopted the same practice, I had a CT scan to see how well the trastuzumab was working. Lying on the CT scan table, and I know this is an experience I think shared by many of us in the room, and listening to that high-pitched hum of the scanner detector array accelerating, I nervously wondered what the scan would show, given that this was likely my last shot at treatment. Next, please. Fortunately, the scan showed improvement with shrinkage of the metastases compared with the scan a month earlier. I continued with trastuzumab, in fact, over the next 9 years. At this point, really, there is no data to suggest when or if we should stop treatment. And my most recent scan, next please, in 2021, fortunately revealed no evidence of metastatic disease. Overall, I've been very, very lucky on multiple levels to have had a dramatic response to targeted therapy for metastatic stomach cancer. With that background, we'd like to shift gears for a moment and share some of the lessons that my wife, Mariana, and I learned during this experience, starting really with a lesson that doesn't need to be reemphasized, that was made so eloquently this morning. Next, please. In terms of the importance of patient advocacy, either for oneself or one's loved ones. It's important, as we've all heard already, to learn about our specific cancer's molecular biology, including known and emerging biomarkers, and also our genetics and our tumor's genetics. Reviewing treatment guidelines from ASCO and from the NCCN can help us be active and informed participants in decision-making with a care team that importantly is aligned with and shares our goals, priorities, and values. Prior to actually starting treatment, next please, Greg, it's helpful to learn about danger signs that should prompt a call to our teams and to plan for exercise and home and nutritional support. Before follow-up visits during the course of treatment, I found it helpful to review, next please, the results of new lab studies. If the results are worrisome, we at least have time at home before the visit to adjust emotionally to the results instead of getting unsettling information during the actual visit. You and your provider can then hopefully better use your limited 15-minute time, which I think Betsy mentioned earlier, visit time, to discuss your options going forward. In this regard, I think it's helpful to have a backup plan in mind in case the test results actually prove to be disappointing. Moving on to chemo, next please, Greg. It's important, I think, to help work with our teams to maximize our comfort and actually increase our chances of completing the prescribed regimen. There are a lot of options now for nausea management. For example, I personally found peppermint tea to be very, very helpful. Working with a mentor, as offered by our group, can be very helpful during all phases of treatment, including surgery, chemo, and immunotherapy. It's helpful, I think, and important to accept, next please, that changes in one's sleep pattern and energy levels are common during treatment, and to sleep when you can or need to. There may be times in one cancer journey, and I agree, Betsy, a journey is not a great term, but I thought it was cosmetically better than ordeal or whatever other term you'd want to come up with. But there may be times where things certainly are not going well. And a number of coping strategies, next please, may be helpful at such times. Setting or resetting your priorities and aligning the use of your time with these priorities is one such strategy. For me, important personal relationships emerged as my first priority, and preparing letters and videos to my family and friends gave me a sense of peace. In general, I think it's helpful to focus on what we can do and not on what we can't do. It may be helpful in this regard to reflect upon the Serenity Prayer on the right side of the slide. We have already heard so much about the importance, next please, Greg, of maintaining social relationships in person and or online, as in our StoCan support groups and as in this meeting. This really can help combat feelings of isolation and loneliness that are tremendously common among patients with all types of cancer. Four-footed companionship can be a source, next please, of great comfort as well. And I enjoyed comparing notes with Betsy again about this yesterday. Overall, I'd say while it's important to be realistic and plan for the worst, a little denial inspired by hope can be a good thing. In this regard, if cure doesn't seem possible, next please, Greg. At a given point, a reasonable goal may be to try to control cancer to buy time. With ongoing research, more effective therapies may become available. In some situations, in fact, cancer may be managed as a chronic disease, and I look forward to hearing more about this in just a few minutes, about this very important concept from Suzanne. From a non-medical perspective, an unnamed sergeant was said to have stated during World War II that there are no atheists in foxholes. Engagement with the faith community can be a source of support in this regard for both the patient and their caregiver. Speaking of caregivers, the multifaceted burden, next please, Greg, and stress on the caregiver may, I think, in some ways actually exceed that on the patient. It's important for the caregiver, next please, to maintain their physical, emotional, and spiritual health as well. We'll move on to a couple of issues specific to gastrectomy for stomach cancer, things that I wasn't aware of at least. One problem I wasn't familiar with in particular, next please, was rheostasis syndrome, characterized by abdominal pain and nausea after eating, usually in a fairly early post-op period. This is due to interruption during gastrectomy of the nerve supply that controls GI tract movement, interfering, next please, with the passage of food down the GI tract. Fortunately, this generally improves with time. More familiar, I think, to many of us, next please, may be maybe various forms of dumping syndrome, early and late dumping syndrome in particular, which both reflect, next please, excessively rapid food transit down the reconstructed GI system. Eating small, frequent meals, with high protein, low glycemic index carbs can help us avoid dumping and late hypoglycemia. Next, please. And next, seen here with the blue arrow, that can occur as part of the late dumping process. I personally, next please, still get hypoglycemic at times, and I find it helpful just to carry around some hard candies. Maintaining nutrition in general, as we've heard, can be a challenge after gastrectomy. While guidelines, next please, call for at least 60 grams of protein, 1,500 calories per day. In fact, nutrient requirements can vary a great deal. For a long time after surgery, I was having trouble gaining weight despite eating enough in terms of calories. One of the nutritionist interns I saw actually raised the possibility that there might be a mismatch between the rapid transit of food into the small intestine. Next, please, Greg. And the slower release of enzymes required for digestion, seen here in green, by the pancreas. The intern suggested, next, please, that I try a pancreatic enzyme, next, please, supplement. And this helped a great deal in terms of allowing me to gain weight. Other useful weight gain strategies include grazing throughout the day. And with apologies to our friends at the USDA, hopefully I won't be reported for this, but eating high caloric density items. Next, please. Next, please. While avoiding, next, please, low caloric density foods. Again, I'm sorry, I know this will be on video, but next, please. At any rate, we're all familiar. Next, please, Greg. With micronutrient deficiencies, and I agree this is an area of unmet discussion or need. After gastrectomy, I personally use a post-bariatric surgery vitamin. As it turns out, our livers usually have about 2 years worth of iron stored up, but at the 2-year point after surgery, I was becoming anemic, and it turned out I was iron deficient. A lot of us don't absorb oral iron very well, and I get IV iron replacement. Another common issue occurring in up to 80% of folks after gastrectomy, next please, is small intestinal bacterial overgrowth. While antibiotics may help improve symptoms, they don't generally cure this condition. Mariana found through her research, next please, that garlic and onions contain a natural antimicrobial compound called allicin, and eating these foods cooked pretty much on a daily basis has helped a lot with my symptoms, if not with my breath, but that's another story. Time limitations today preclude additional detailed discussion, next please, of other long-term survivorship issues, but it's important to note that there are specialized clinics that now help, next please, with cardiac, next please, kidney, next please, and immune system problems after treatment. There are also resources available to help with neurologic and psychologic issues, including peripheral neuropathy. Next, please. CNS disorders, including, next, please, chemobrain, which Jeff alluded to earlier. Next, please. And anxiety, which I suspect many of us have experienced. Next, please, as well as PTSD. Next. Next. One of the greatest sources of stress and concern to us is recurrent or metastatic cancer. Next, please. Recurrent or metastatic tumors may demonstrate molecular profiles that vary from the primary tumor, as well as chemotherapy resistance, both of which may make treatment more difficult. Even our best scans capable of picking up a nodule a fifth of an inch in size, next please, are not detecting cancer until over 100 million cancer cells are present. Recently developed assays of circulating cell-free tumor DNA promise to allow much earlier detection of persistent or recurrent cancer. Camilla, I stand in awe of your experience with your team in using very effectively one version of this molecular residual disease test, Signatera, in guiding your own treatment. Well, why is early detection of recurrence so important? Next, please. And I'm sorry for the diagram on the right, but basically over time, single cancers can mutate, as seen in the diagram, into many genetically different tumors, some of which may be more aggressive or more resistant to chemo. Detecting and treating recurrent tumors can limit this mutation process. Second, as we know, our immune cells, seen in blue in the slide on the lower left, may be able to destroy cancer cells, seen here in yellow. The immune response may be most effective, though, when the tumor burden or number of tumor cells is relatively small compared to the number of immune cells. Catching and treating recurrent cancer early can keep the ratio of immune cells to tumor cells more favorable. Well, we are running short on time, so again, I'm going to put these slides up there so they're on the video. These cover the importance of multi-cancer early detection testing, which is particularly important, I think, for those of us with rare cancers such as stomach cancer. Basically, a blood test which allows screening for multiple types of cancer at once. And we've heard about Guardant, and there are other companies in this space. I think this will be a very important development. We are going to, again, just race through these slides, so they'll be available for review on the video in terms of survivorship care planning. And I would like to conclude, though, with two comments in terms of survivorship care planning. First, there are some very exciting developments with artificial intelligence that I think may help us address many of the gaps that were identified during our town hall. In terms of survivorship care planning in particular, this is a prompt I put in for ChatGPT 3.5 a few days ago, just asking for a survivorship care plan for a patient undergoing gastrectomy. We need to advance a few slides from here. Greg, I'll tell you when to stop. Next, 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 next. Perfect, thank you. I hope everyone caught. Will be a brief quiz on this at the end. But this is the prompt: as ChatGPT, provide a care plan for a patient undergoing gastrectomy with adjuvant FOLFOX and trastuzumab. Next, please. In literally 2 seconds, ChatGPT provided a pretty respectable 5-page plan, including advice circled in red to monitor for cardiotoxicity given the trastuzumab history. Well, in closing, and I apologize for going over, which is terrible as a moderator in particular. Next, please. We are not alone as we face stomach cancer. We have a number of partners that really support us in a robust ecosystem of innovation that has been responsible for the majority of new cancer diagnostics and therapeutics developed worldwide. I'm personally grateful to many of our partners in this ecosystem, including those from the NCI, FDA, academia, ASCO, and industry who have taken time from their schedules to join us today and to support this program. I'm looking forward to doing our part to keep this innovation momentum going during Advocacy Day through discussions with our policymakers tomorrow. Thank you.